In Module 8, we're going to be talking about preparation and care for the time of death. Professional caregivers are especially impacted. We know that everyone dies. Sudden death is less than 10% of those who die, but more than 90% die of chronic illnesses. So professional caregivers will be exposed to death during their entire career, including care for adults who die suddenly, such as from accidents, heart attacks, etc., patients who are diagnosed with 6 months or less to live, such as those with cancer, older adult patients who die from chronic illness, such as diabetes, multiple sclerosis, cardiac disease, COPD, multiple systems failure, and other processes of aging, stillborns, infants who die shortly after birth from congenital defects, sudden infant death syndrome, children who die from accidents or acute or chronic illnesses. So professional caregivers, especially nurses, have more real exposure to death than other healthcare professionals. The final hours to days before a patient dies may be the most significant moments for a patient and their family as they prepare for death, say their goodbyes, and complete their end-of-life closure tasks. The nurse is often the one to facilitate a dignified, comfortable death that honors patient and family choices. As such, these moments are made even more significant with the nurse taking on roles as advocate, companion on the journey, professional caregiver, educator, and supporter. The nurse's challenge is to gain knowledge and skills to promote competence and provide dignified end-of-life care to patients and their families in any practice setting. Interpersonal competence includes empathy, being able to put yourself in another's place, unconditional positive regard, also called non-judgmental acceptance, genuineness, which is trustworthiness and openness, and attention to detail or critical thinking. During this time, more so than any other point in illness, nurses and other professional caregivers must be comfortable with just being with the dying patient and family. This involves being present and bearing witness. Care of the dying is an interdisciplinary activity. Nurses should collaborate closely with physicians and all team members to provide care at this time. Dying is a unique experience. There is no typical death. Each person dies in their own way, their own time, with their own culture, their own belief system, their own values, and their unique relationships with others. When patients are aware that they are dying, they usually know where they want to die, with whom they want to die, and how they want to die. You can refer to Figure 3 in your supplemental materials, Hierarchy of the Dying Person's Needs, for more information on this. Nurses and other professional caregivers need to advocate for patient and family choices in relation to where, who, and how. Dying is a physical, psychological, social, and spiritual event. Patient and family together are the unit of care. Family is defined by the patient, which may include friends, significant others, partners, and lovers. To meet the needs of dying patients and their families, an interdisciplinary approach to care is critical. Nurses and other professional caregivers should seek support from other professionals in care of the dying, including psychosocial professions, such as social workers and counselors, spiritual care providers, such as pastors, chaplains, priests, rabbis, and other spiritual advisors, nurses' aides, volunteers, and physicians. Each discipline has expertise in specific areas, and that combined expertise makes the highest quality care possible. The team will need to do an individualized assessment and identify problems, issues, and opportunities specific to patient and family choice in end-of-life care. At the time of nearing death, the interdisciplinary team serves as advocate for the patient and family and provides interventions directed at comfort, minimizing physical, psychological, social, and spiritual pain and suffering, and honors and respects patient and family choices and wishes. The nurse and other professional caregivers can be advocates. In collaboration with an interdisciplinary team, nurses and other professionals need to be advocates for patient and family choice by providing optimal end-of-life care in any practice setting, open, honest communication with the patient and family, education, and support to patients and families at the end of life. In end-of-life care, setting is very important. So the professional needs to advocate for the patient and family in any setting. Deaths occur in hospitals, homes, nursing facilities, assisted living facilities, prisons, hospices, and other healthcare settings. In the hospital setting, patients may die in intensive care or the emergency room, and infants may die in labor and delivery. No matter where or how death occurs, the nurse especially has the responsibility to follow patient and family choice and create a supportive physical, psychological, social, and spiritual care environment. Patient and family choice may include advocating for where the patient wants to die and with whom they want to die. Each setting should provide a supportive physical environment, which may be challenging for the nurse. Putting family pictures on the wall in a nursing facility, bringing a favorite blanket to the hospital, allowing a pet to visit in an assisted living facility, allowing family members to visit or stay during a death vigil in a prison are part of a supportive physical environment that may be comforting to the patient. In the hospital setting, visiting hour restrictions and lack of space for privacy may require the nurse to be creative in providing a quiet place for family members to find privacy to be alone with loved ones. In a nursing facility, privacy may also be an issue in terms of space for family members to spend time alone with their loved ones. These situations and many others challenge nurses and other professional caregivers to creatively find ways to provide a supportive physical environment according to patient choice. Nurses and other professionals should avoid a change of setting in the final stages of life. Transferring an imminently dying patient from a nursing home to a hospital can be very disruptive and distressing. The setting should only be changed as a last measure, and preferably only if the patient and family request the change. Patients and families should be given options in care, educations about care, and/or increased support so the patient can die where and how they choose. Let's talk about open and honest communication as death approaches. The team should be open and honest to promote trust and informed decision-making. In all communication, you should convey caring, nurturing, sensitivity, and compassion. You should provide information in simple, uncomplicated terms. Avoid overwhelming the patient or family by providing simple answers to questions in accordance with patients' and families' understanding and readiness for responses. Diminish threats by providing the information the family and patient ask for. Family members may be tired. They may have difficulty concentrating, focusing on present and not future. Nurses and other professional caregivers may need to answer the same questions and provide the same information over and over, as patients and families may be in crisis and their ability to retain information may be greatly diminished. Patients may have a greater awareness that they are dying than those around them. If a patient asks if they are dying, be honest. Explore concerns and fears with the patient. The patient may fear the dying process, how they're going to die, and how they're going to tell their family. If the patient is fearful, if the family is fearful of the patient knowing they're dying, address these concerns and fears. Educate the family that the patient may already know they're dying. Encourage open and honest communication between the family and patient. Maintain presence. Address the family and patient's hopes, whether it be to see one more day, to spend a day without pain, see a grandchild born, attend a wedding, live through a holiday, go into remission, or have a good death. Do not destroy hope. provide companionship, active listening, and your simple presence. Provide reassurance that someone will be available during the dying process. Family education about care at the time of death. Education can empower caregivers and patients to make informed choices about where they die, with whom they die, and how they die. You need to educate with verbal information and written materials, demonstration, or role modeling. Keep your instructions simple, not rushed. Use repetition. Provide small amounts of information at one time, as families are already overwhelmed with the magnitude of the situation. Provide information about signs and symptoms of the dying process, what will happen, what may happen, what they can expect regarding physical, psychosocial, and spiritual needs. Provide information about care management. Generally, the more the family, including children, are involved in the care of the patient, the better they will cope after the actual death. The imminently dying patient. Let's talk about signs, symptoms, and interventions. Determining prognosis. No one can predict the exact time of death. Some patients seem to instinctively know when death will occur. Prognosis is affected by the disease, the patient's will to live, their desire or choice to wait for a special event, such as a birthday or a holiday, or completion of life closure goals. Signs and symptoms of the dying process only serve as a guideline. Not all patients experience all symptoms, and the signs and symptoms do not necessarily occur in sequence. The nurse and others will also need to assess for other causes of symptoms other than the dying process. The dying process is a natural slowing down of physical and mental processes. Signs and symptoms can occur days or weeks before the death, or may be present only hours or minutes prior to death. Psychological and spiritual symptoms and interventions. There's a fear of the dying process, fear of abandonment, fear of the unknown, nearing death awareness. One of the stories from Final Gifts is Bobby's story, and you have that as an audio download to listen to Bobby's story. These are the types of things you may hear when a person is having death awareness. There may be withdrawal from family, friends, and caregivers, and an increased focus on spiritual issues. Physical symptoms. Signs and symptoms associated with dying may occur months, weeks, days, or hours before death. Close collaboration and communication with the doctors is essential regarding this information. A lot of the literature talks about confusion, disorientation, and delirium near the time of death. There may be weakness and fatigue, increased drowsiness, sleeping, and decreased responsiveness. Decreased oral intake. The family may be concerned that the patient will starve to death. In our society, we think that nutrition is equated with caring. Provide information about the pros and cons of dehydration and accept the family's choices. The pros of dehydration. It causes increased production of ketones, which result in sleepiness and euphoria, and a decreased urinary output. A decreased GI fluid resulting in decreased nausea and vomiting and decreased abdominal distension. There may be an edematous layer around the tumor that shrinks if there's a tumor present. Increased opioid peptide production resulting in increased endorphin levels and naturally occurring analgesia. Decreased gastric stimulation resulting in no hunger. decreased lung secretions. So these are all things at the end of life that would be pros of allowing the dehydration to occur. The cons of dehydration is there's a potential for dry mouth, but you can use ice chips and other mouth care. Another con is feeding is symbolic to nurturing, so if you're not doing that, you may feel that you're not caring. You may feel that you're appearing to abandon the patient or that you're not giving them basic nursing care. There may be decreased or lack of swallowing reflexes. There could be surges of energy, restlessness, and or terminal agitation, fever, changes in bowel elimination, including constipation and diarrhea, and incontinence. These are all things that can happen towards the end of life. Let's talk now about universal symptoms of imminent death. And this means death is going to occur, and it's going to occur quickly. A decreased urine output, cold and mottled extremities, vital sign changes, respiratory congestion, including respiratory bubbling, breathing pattern changes. The role of the nurse and other professional caregivers in pediatric end-of-life care includes working with the dying child, siblings, parents, and extended family and friends. Children usually know they have a terminal illness, even if they are not directly given this information. Children can usually detect subtle changes in the way staff and family members are reacting to them, caring for them, and talking to them. Some family members prefer not to tell the child that they have a terminal disease. It is the nurse's responsibility to respect the parent's choices and decision-making while assessing opportunities to encourage open communication between the parents and the child. Provide support and caring without taking away the realistic need for hope. Some children do not want to talk about the disease, but want to know that someone is available to listen if they do choose to talk. So talk to the child at their appropriate level of understanding. A child might let the nurse or other professional care providers know that they're finished talking by walking away, moving away to play, changing the subject, their body posture, and other nonverbal cues that signify withdrawal. Often, presence is the most powerful intervention for both children and their families. Parents should be encouraged to care for the child and include other children in care, encouraged as they do a life review. Siblings should be assessed as they are often forgotten as parents are focusing on the dying child. Assess for acting out, negative, or the perfect child behavior. Allow siblings to continue their extracurricular activities by finding resources and support people to take the child to these activities. Allow siblings to verbalize feelings in a safe place without them feeling as though they're making their parents feel worse. Provide support to other extended family members, including grandparents, stepbrothers and sisters, step-parents, and classmates. With the dying older adult, they may have addressed their own mortality prior to their impending death, but don't assume this to be true. Factors that positively influence the elder facing their own mortality are philosophically accepting of what life has to offer, numerous encounters with death and learning how to cope with it, personal loss of their parents, friends, spouse, or children, perceiving death as developmentally appropriate, and support from religious beliefs in the concept of life after death. Factors that negatively impact acceptance of death are multiple losses in rapid succession, leaving the elder emotionally exhausted, death of their significant other, resulting in fewer support people to them, and a societal assumption, which is incorrect, that elders easily accept death. Let's talk now about the death vigil itself. Family will often want to be constantly at the bedside during the hours to days before death. In some situations, They may be uncomfortable at the bedside due to fears or other personal reasons. It is important to explore family preferences for a bedside vigil, address their fears, and provide education and support for the family during a vigil. Common fears are fear of being alone with the patient, fear that the patient will have a painful death and they will have to watch their patient suffer, fear of being alone when the patient dies and that they do not know how to react or what to do, fear that they will not know if the patient has died, fear of giving the last dose of pain medication and actually causing death. Nursing and professional caregiver interventions can calm family fears. You should increase support and care to the family and patient by close collaboration with the physician and increasing the presence of all disciplines, including social workers, nurses, aides, volunteers, and pastoral care. Seek increased presence from family members, friends, and church groups during this time. Reassure the family that the patient will be kept as comfortable as possible. Educate the family on the signs and symptoms of the dying process, signs and symptoms of death, what they should do if they suspect a patient has died, and to call the nurse for any questions or concerns that they may have at this time. Role modeling comfort care is an effective way to educate family members about care needs. Intensive physical comfort care, including mouth care, turning and positioning, pain, and symptom management. Intense spiritual comfort through presence, prayer, rites, and rituals. And remembering to honor cultural beliefs, traditions, rites, and all rituals. Now let's talk about the actual death. Communicating the death. Telling the family that the patient has died should be done with great sensitivity. Be open and honest in your communication and provide small amounts of information at the family's level of understanding. Information about the death may need to be repeated due to the family feeling overwhelmed or shocked by the actual death. The news of the death may be easier if the family is prepared in advance and experienced anticipatory grief. Signs and symptoms of death are absence of heartbeat or respiration, spontaneous release of stool and urine. There could be no response at all. Pupils may be fixed, the body color pale and waxen as blood settles. Body temperature drops. Eyes may remain open. The jaw may fall open. The death pronouncement might be done by a nurse or a doctor. They should check the policies in their setting and state, as well as licensure and practice guidelines in relation to pronouncing a death. In a hospital, nursing facility, or prison, there are usually policies and procedures for the actual death pronouncement. The death pronouncement procedure is to identify the patient, note the general appearance of the body, lack of reaction to verbal or tactile stimuli, lack of pupil light reflex because the pupils are fixed and dilated, absent breathing and lung sounds, absent carotid and pulse for a full minute. Document death, including the patient's name and time of call, who was present at the time of death and time of pronouncement, detailed findings of physical examination, date and time of death pronouncement, either by the nurse or the time physician, either assessed the patient or was notified. Others who were notified, such as consulting physicians, staff members, if a coroner was notified, why and outcome. Plans for disposition, including any cultural or religious traditions, autopsy, organ, or body donation. Care immediately following the death. Following the death, family members may feel numb and confused about what to do next. The nurse or other professional caregiver should explain the process and procedures for care of the body immediately following the death. This should be done in a private, quiet place. Nursing and professional caregiver responsibilities for care after death are evaluating the circumstances of the death. In any setting, the circumstances of a death should be evaluated. Any signs of foul play, suicide, missing medications should be prepared and reported to the appropriate authorities and/or the coroner. Nurses should know practice-setting guidelines and state procedures for reporting suspicious or existing circumstances of a death. If the patient is an organ donor, follow procedures as planned and in accordance with state setting guidelines, policies, and/or procedures. Removal of tubes, medical supplies, and equipment. Following the death in any setting, medical supplies, equipment, tubes such as catheters and IVs should be removed from the room immediately. An exception would be instances where such tubes would need to be left in place until a coroner approves such measures. The goal is to provide a personal closure experience for the family, leaving the family with memories of the deceased as a loved one rather than as a patient. Bathing and dressing the body. This shows respect and provides dignity for the patient and the family. For some families who have chosen cremation or no funeral or memorial service, this may be the last time that they can physically touch and be with the deceased. Place dressings on leaking wounds. Diaper as needed for incontinence. Position the body in proper alignment. Place dentures in the mouth. Ask the family if they would like to assist with bathing and dressing. Ask the family if they have preferences in clothing for the deceased or preferences in care of the body. Some cultural practices dictate the care of the body after death and who should provide that care. It is the nurse and other professional caregivers' responsibility to assess, honor, and advocate for cultural practices. The goal is to provide a clean, peaceful impression of the deceased to the family. Time with the body and removal of the body. You should provide as much time as needed for the family to say their final goodbyes and let go. This will help facilitate closure. Rigor mortis occurs 2 to 4 hours after death when stiffness sets into the body. Position the body correctly for viewing. Be aware that if the body is turned at this time, air may escape the lungs and the nurse and family members may hear a sighing sound similar to breathing. Alert the family to this possibility. If the family has planned for burial, embalming is best done within 12 hours of death. The nurse should be aware of cultural considerations. In some cultures, time with the body may need to be extended beyond a few hours to days. The body should not be removed until the family is ready. Viewing and closure needs should always be met. During the physical removal, treat the body with dignity and respect, covering exposed body parts. Covering or uncovering the face during removal should be based on the family's choice. The physical removal may also be dictated by their cultural considerations. In most settings, the funeral home will require a time of death, Social Security number, diagnosis, physician, and survivor contact. You should assist with phone calls. Family members may need time to adjust to the immediate loss before they are able to make these phone calls. Some family members, however, find healing in immediately telling the story of the death to family and friends. Offer to assist with phone calls and assist per the family's request. Help with notifications, notifying the physician, co-workers, other involved healthcare agencies. They may need to also visit or to seek closure with the deceased. Destroying medications. In a home setting, refer to local and state laws regarding destruction of patient medications. If the family asks the nurse to leave medications for them, the nurse should assess reasons and psychological issues for the request. Offer to call their physician as indicated for an assessment of any survivor issues or problems and to obtain a prescription unique to their needs. Assist with funeral arrangements and memorial services. Funeral arrangements are best completed prior to death, but that option is not always available. If the family requests, provide options to promote family choice. Pastoral care can assist with services and help facilitate decision-making about funeral and memorial services. Help initiate bereavement support. Following the death, the nurse and other professional care providers should initiate bereavement support by providing compassion, active listening, and just presence. Assess grief reactions and assess bereavement risk factors. Follow up bereavement support through phone calls, cards, attending the funeral and memorial service and visits are help for the family and nurses and other professional care providers to have closure with the deceased. It's very common, especially for hospice care nurses, to come to the memorial or come to the actual funeral. For survivors in need of continued bereavement support, refer to community resources, including hospice and support groups. Survivors may need to know they are not alone and that they will not be abandoned to cope with their grief alone. This includes support for the nurse and other professional care providers. If you need help, you should also ask for it. Verbalize this. You may need to have a clinical debriefing after the death to deal with your own grief and loss issues. In conclusion, remember that care of the family and the patient at the time of death entails unique concerns best provided by an interdisciplinary team. Close collaboration is extremely vital. Everyone may have needs at this time. Don't forget, as a professional care provider, to take care of your needs as well.